heat to the environment. Conduction, conduct something means to actually touch, right? Now, the thing you're touching is colder. And when you touch it, you will lose heat via actually coming in contact with that cold thing. Which is why we don't place babies on cold tables. They will lose heat, they will go into hypothermia. And that's a whole big skew that we're gonna
So where do
cover.
you put the babies?
We wrap them in warm blankets and we put them in their bassinets.
Just throw it.
When you're examining them, you don't put them on the exam table?
Yeah, but there's a blanket.
I don't know, I want a baby.
You don't need one. You just don't put anybody or anything. When you go to the doctor, you don't get on the table just all willing it. They usually have at least a piece of paper and things. So radiation, your body is losing heat to the environment. Is that clear? Conduction means to conduce, means to touch something. Your body is losing heat via touch. Convection is a fanning movement. Convection is air literally moving, which is why when you're hot and you do like this, it works a little bit better. That's called convection. That is not conduction. Conduction, conduce, means to touch. So now you gotta sit with these four terms and memorize what I just said and put them into logical sense. Because you can very well confuse convection and conduction simply because they sound alike. But if you actually say the name, then you'll hear the difference, because to
Like
conduce means to touch.
So,
It's like an electrical
radiation.
conduction.
You got it.
radiation.
Convection is like an oven.
Yeah,
Convection
convection
is
is
like
convection.
an fan
It's
for hot
air movement.
Fans
Convection
for hot
is
air.
air movement like an oven.
Radiation, you just, it's still.
Hmm?
Radiation was,
Still.
Yes, it's just a cold air. You're losing heat to a cooler environment.
radiation?
Yes. You're losing heat to a cooler
Radiation
environment.
is a different environment temperature.
A colder environmental temperature. So Ray, take it all the way to the corner of the NAR, please. The people that, I think the lady that's here before me uses it, but you'll never see me behind that thing. I don't know why.
And then I can't see.
I don't know what that does. Y'all come up here, y'all get right behind
That
it
makes
too.
you
I'm
feel powerful.
It makes, it gives you power.
like, okay.
Command authority when I'm there.
So, radiation, the warm body loses heat to the environment. Nobody's touching anybody, nothing's touching. Stop touching. When you start touching, you're
Conduction.
conducing. When air starts moving, it's convection, and evaporation is, like we said, sweat, heat lost through water, which is why we don't take babies out of the womb and dry them off and keep them in that wet towel, because they will lose heat via evaporation. We dry them off, toss that, and then put a nice, fresh, warm, dry blanket.
I was telling my mom about that, and she said that when I was a baby, I had a really bad fever, and they took me to Children's Hospital, and they put me on an ice bed. And so they were
Don't do
all
that anymore.
they were all worried about me, and then they would leave, and I would turn blue, and so my mom would grab me and warm me up again, and then she'd hear them coming, she'd put me on the bed.
She
did
had
that-
sense.
She did that for like 10 minutes, and then they got scared, like, oh my God, the temperature's not going down, so in the end, she left me there, and my temperature finally went down.
Well, she had enough sense to know that you were turning blue and that that wasn't right. Ladies and gentlemen, we don't do that anymore. We'll never say that again.
Really?
For a patient can go into shock.
Yeah,
That's what
I
you
think
were
she said it
doing,
was like
going into
an
shock.
or something.
So what we will do for babies with fever, number one, remove the clothing. That'll be number one. Number two, we will take a cool compress, like a washcloth, a cool washcloth, and we will pad the axillary area. We will not apply ice. We will not apply ice. We will not apply ice, but we will keep recooling, run some more water, some cool water over the, washcloth, and we will apply it to the axillary and the forehead.
But that's not just for baby, right? That's also like if a person is hypothermic and you're trying to warm them up, you're not supposed to sit them, like, put them like right to direct heat or
Yeah,
direct.
everything that's contraindicating,
You're not supposed to do it
Quickly.
excessively.
temperature extremes.
Also, like when you defrost chicken, you're not supposed to just put it like somewhere hot. You're supposed to let it thaw
In the fridge.
In the fridge.
In the
or
fridge.
Before it comes out.
The night
Slowly.
before in the fridge. So time to take the turkeys out of the freezer. Alright, and so there are your 4 ways of heat loss. You will see it over and over and over again. We started talking about this before this even started. We just said that the temperature, the hypothalamus is the body's thermostat, and so that's what it is. It sends its changes, and it sends signal to the rest of the body to do whatever it is that the rest of the body needs to do, so that we can, do whatever needs to be done. So if the temperature is too high, then we'll send the blood vessels to dilate. Why? So that we can lose heat through those blood vessels. We call it being flushed. And if the temperature is too low, we will then constrict to try to hold on to that nice warm blood. Okay, moving on. Always something about aging. I tell you guys, every single system, you haven't really seen it yet, but every single system has to do with the age. I've been pulling them out of your test slowly but surely, because it takes me like 3 or 4 hours to create your test. What's going on with aging? Elastin. Elastin is what stretches the skin. Collagen is what strengthens the skin. So elastin and adipose tissue start to diminish, and we have what's called wrinkling. Whenever there's not enough adipose tissue, one looks wrinkled. Collagen is for the strength, and the strength now, they have a hard time healing because the skin isn't as strong as it used to be. So they get a lot of skin tears. This is a whole other topic. We're gonna cover this, I think right before the burns. Their skin becomes thinner and transparent, so we cannot handle the geriatric patient the way we can handle each other. You be careful, you grab them and you're gonna tear off your whole arm. It's called degloving. We've seen geriatrics who got caught by their arm and went this way and all the skin came off.
Oh my
We call
Lord.
it degloving.
Yeah, it's bad. It can be nasty.
They have prednisone thin skin. Their skin is paper thin. You can't grab a piece of paper and expect to hold on to it. It's going to tear. Just like the patient's skin will come off in your hand if you're not very careful with them. The skin and the sebaceous. What is sebaceous? Oil. Okay? The oil is reduced. Therefore, they have drier skin, yeah? Their skin is a little bit dry. Do they need to bathe every day? No. They're going to continue to dry out their skin. Not only do they not need to bathe every day, but they also need to be moisturized a little bit more frequently, okay? That bathing and that soap, they need a mild hypoallergenic soap, because all that soap, just like babies, we love for them to smell good, but they smell good naturally. Johnson and Johnson and yeah, no, we're not there yet. Come on, babies. And so all this Johnson's and Johnson's perfumed this and the Dreft that and they're all making them changing. I don't know if you've noticed it recently, but they're all changing their products to hypoallergenic,
Yes.
non-scented. Because that was a bunch of foolishness we were doing to those skins of those little babies, putting all that perfume on their skin, all that extra stuff.
They smell good, naturally good already.
They smell good naturally. All right, and so this is a skin tear. Ladies and gentlemen, there's a whole lot to do with this shindig. Let me just say it now. Number 1, please clean it with either sterile normal saline. You need to do what's called approximation. I believe we've spoken about approximation before. Anybody who say approximation? Okay, you put the skin to skin. It's approximation. Lining something up. It's approximation. So this, at one point, was down here. They cleaned it with some normal saline, and somebody took the skin and approximated it. They put it back where it needs to be, so it can be in contact.
Oh, you
With
mentioned
the-
that with the bones.
Hmm?
Didn't you mention that with the bones?
Probably, I don't know. I should have mentioned this
Put it
before,
where you should
but
have.
we want to go ahead, that's reduction.
Oh, okay.
So we want to go ahead and approximate the skin back where it needs to be. If we do not do that, we're going to get a nice scab on here. This skin will dry up and fall off. Because why would it dry up and fall off?
It doesn't have, it's not connected.
Because it's not connected. There's no blood supply to it. The epidermis, the dermis is avascular.
But doesn't it help it heal when you, like, to keep it covered? like
Absolutely.
Protection?
Absolutely.
Why you do that?
So when this skin is down here, first thing you're gonna clean this wound with sterile saline, number 1. Number 2, you're gonna take this skin that's down here and you're going to do what's called approximation. You're gonna line up the edges, just like this. This one could have gone maybe a little bit more. could have fixed that up a little bit more. So now the skin is in contact, and we have a nice, how do you say, contact, that's the word I'm looking for. And now a nice blood supply and all that good stuff will help this to heal. Then we're going to put a clear dressing over this, a Tegaderm or a Telfa pad, Adaptic, not Telfa, Telfa Macerates, an Adaptic pad. I don't know how much wound care you guys have seen in the clinic or in the lab. I don't know what's in the lab there as far as wound care dressings, but there are some basics. So I'm not gonna go over all the wound care, so much to go over, but your basic. You need to know what an Opsite is, a Tegaderm is. It's that clear plastic one. So you can see the thing, okay? A Telfa pad. A Telfa is a piece of gauze, but it's non-stick, it's non-adherent. You please don't put anything, please don't put gauze on this. What's gonna happen if you put gauze on this? It's gonna tear off the skin when it comes off. The blood is gonna be on there, it's gonna dry and stick. Then you have to soak this off. Or else, when you tear it off, you would undo everything that you worked hard to do. So please don't put gauze on these types of wounds. Those are meant for wounds that are soppy, that are draining, and then you can put gauze in there to absorb that moisture and wick that moisture away. You need moisture here. So approximate it, wash it, approximate it. You can put a piece of Telfa on there, because Telfa don't stick. But what this thing really needs is air. So you can put an Adaptic, a Tegaderm on this, and then for the next 3 days, you're gonna eyeball it like crazy, because you're looking for infection, signs and symptoms of infection. You're going to measure the wound, and you're going to take a picture of the wound with the ruler on there and the patient's name. And dear Lord, please write which hand it is. You're gonna put that in your chart, and your picture is worth 1,000 words. You're gonna watch it like a hawk for infection, especially if they're on some type of medications that I will not speak of right now. All right. More issues with aging. The melanocytes, okay, aging, everything goes down. Except for the toenail. That's one thing that goes up.
Except what? The toenails get thick. Everything gets thin.
That's it. Aging, everything goes down. Except for toenail and ear hair. That's it.
Oh, yeah.
Yeah. Nose
That's
hair,
it.
ear hair, eyebrows.
That's it. All right. So the melanocytes will begin to decrease. That means your patient is at risk for not only sunburn, but for skin cancer as well. The hair follicles, everything goes down except for the toenail and the ear hair. Okay? And so we see age spots or liver spots as melanocyte production begins to decrease. Okay, moving on. Skin disorders. We gotta cover 1, 2, 3, 4 categories. We're going to cover the inflammatory, the fungal, the bacterial, and the parasites. Let's do that now. How do we prevent these things? Number 1, keep clean and dry. Right? Keep your patients clean and dry. Frequent bathing with hot water and soap. A regular soap will dry out patient's skin. So we use a nice, hypoallergenic soap for them. Don't use Palmolive and Dawn and those are dishwashing.
Yeah.
Zest. That's the one. Zest. That's the one. I like Zest. But don't use Zest and Caress and all this.
Dove is hypo.
Zest is a step up from what they use in the Dell.
And the spring.
And that white soap. Don't use that on your patients. They just really.
Safeguard.
Don't bite soap.
No, the white soap that you get in the long term in the hospital. That little bar soap you get them in the hotels.
Oh.
Go find a nice, request that, the physician order, hypoallergenic, thing for your patient. You just never ask for it. And so, that stuff will dry up their skin. You know that hotel soap.
It dries our skin.
It dries your skin. So, Can you imagine theirs? Their sebaceous glands are, you know, their sugar-first glands and sebaceous glands are already dried up. All right, diet. What about diet?
High protein,
Protein,
Protein.
Vitamin C,
vitamin C.
Vitamin C,
vitamin E,
A.
vitamin E, A, hydration. All right, that's enough of that. Again, they do not need a full bath every day. We want to clean what's visibly soiled, and they should be alternating the amount of time, especially not hot water. Something in there that we're going to talk about in leadership. We're going to talk about the 5 forms of negligence, including beneficence and non-maleficence. Have I seen maleficence this weekend? You shouldn't have.
No.
Okay, all right. I thought it was so good. It was better than the first one. Okay. Yes, it was. Wait till December and watch it. Wow. Wait till December.
It's not gonna be around.
It will be. It'll be on
You watch it, get the DVD.
Just watch it illegally online.
Alright, legally.
Pirated illegally online.
That's what you used to do, Ms. Sharon, watch it illegally?
Huh? Huh?
Never
Gonna
mind.
help us then.
No,
We
you
didn't
get
hear
it
from you.
on, no, I said get it on Blu-ray. It'll be on
I heard
Blu-ray.
it pirated.
No, get it on Blu-ray.
Whoa.
Don't watch
Whoa,
those. They mess
she
with
said
your
pirated.
eyes.
With the pirated one?
What?
No,
They're
don't watch,
good
don't
at
watch
the
those.
movies,
No,
those
no. Those are bad. Anybody with visual problems don't buy bootleg movies. You need high quality, high def.
What is that in the car?
To be able to see that. And don't watch something like Maleficence in no bootleg. That is an injustice.
Quality stuff now?
Don't do it. Buy the Blu-ray. Please buy the Blu-ray. Okay. H, so again, they're full back, not unless they're visibly soiled. I was gonna go somewhere with this just now.
So my son, hot water.
Hot water, yes. Maleficent. Not Maleficent.
Maleficent.
Maleficent?
Not Maleficent. Non-maleficence. Maleficent.
None.
Term is called non-maleficence. You're gonna learn 5 terms in leadership. I don't know where that is in your,
No, we learned it more.
We learned it
Non-maleficence is like not doing
do
intentional
no harm.
Yeah.
And beneficence,
is doing
to
good.
do good. Ladies and gentlemen, you will be sued if you run a bath for a patient and put them in the tub without
Check it.
checking the temperature. And how do you check the temperature of a bath for a patient?
You want to, you want to hear?
Thermometer?
Right
Oh,
in
here?
a nice sensitive area of your body. Your hand is so used to heat, and you could probably grab a pot with your hand and be good for a little bit. This here is not. So you take that water and you put your elbow in there, and you're gonna feel a difference. You can take one hand, go home tonight, set your dishwater, same temperature, put one hand in and put one elbow in until you can feel a difference. Alright, so this is preventing harm to your patients. It's called non-maleficence, okay? And its cousin, beneficence, means to do good. So you'll hear those terms again, they'll be coming back. Raising the side rails up, non-maleficence, okay? Putting the bed in its lowest position. Those are standards of care that we expect every single nurse all across the country to be able to say with no qualms. All right, and so we got to deal with sun exposure, and I believe there's maybe a little bit of changes in the National Skin, those people council with this. But sun exposure, can anybody tell me about sun exposure? When do you want your patient exposed to UV light, sunlight? Early in the morning, before the sun hits the 10 o'clock or 11 o'clock hour, depending on what season we're in, and or late in the evening when the sun, depending on 4 or 5, depending on the daylight savings time is next week, next month, next something.
Next month. November.
Next month.
You guys just a couple of weeks. I think it's a couple of weeks.
No, I
Yes.
think we gained it.
November 2nd.
No.
Blows.
It's fall. Time is gonna fall back.
Fall back.
Yeah, but we get an extra hour of sleep.
Sure.
Depends on what time you go to sleep.
That's true.
So we're gonna lose daylight savings time, and so by 6 o'clock, 7 o'clock, it's already dark outside. So then we recommend
God.
sun exposure for those people around the 4 o'clock hour. Never ever when the sun is directly overhead between like 10, 11 and like 3, 4 when the sun is at its peak at its highest. Outside of those parameters are the times that we recommend. No more than 30 minutes a day, no more than 30 minutes with appropriate sunblock, SPF like 30 and up, depending on your skin tone. I can do an SPF 15 or an SPF 30. Some of you in here need an SPF 45 because you're so fair.
Do you wear sunscreen every day?
I do not.
Yes.
Not even your facial cream?
It's different than Florida sun. I'm from Belize, guys. I know a real sun. And so, now
Oh,
because
our
I know
sun's
real
fake.
sun, yeah, this is fake sun.
In
Because
the
I know
air.
real sun,
Everything's fake.
I have manipulated myself and done a disservice to myself, saying this sun is foo-foo sun.
Because it so causes skin
It can still cause skin damage and skin cancer.
You know better.
But it doesn't feel like the Belizean sun, so I don't feel like foo-foo sun to me. Just like rain. You people don't know rain. Anybody from experience real rain?
Heck yeah.
That's
Where,
crazy.
Cindy? Okay, where?
Philippines.
All righty then, that's rain. This shitty day I have out here, my God, people are crashing.
Showers.
Like I'm walking in there, like it's raining. Oh, it's okay. So this is not real rain. You need an umbrella. God is spitting on us. Let's move
Oh
on.
God, I hate pouring rain.
Real rain. Real rain is when you're driving and you hear
You can't see anything.
and you can't see
Can't see
anything.
anything.
You have to put your hazard light on, ease yourself over, and stay there for the next 20 minutes.
That's Florida.
That's Florida. That's rain.
Florida, Mississippi.
You got it. All right, we're gonna talk about skin tears. We're not gonna talk about the pain marking classification right now, because we're gonna go into stage 1, 2, 3, and 4. I mean, we're not gonna talk about the categories right now with this one, the skin tear. For I've already told you what to do. What did Ms. Hume say? This stuff right here. She said clean it with normal saline, approximate those edges real good, put a bio-occlusive on there, watch it like a hawk for the next 3 to 5 days, measure it, take a picture, please put the patient's name and which hand or leg or foot or arm or whatever it is, because it's hard to tell from a picture when the picture is like this. All you see is this area. You don't know if it's a hand, a foot, a butt, a leg, you don't know. And if it's an elbow, please back out, because elbows look like butts when you take a picture of an elbow. It looks just like butt crack. So be very careful and
Not a butt
so
crack.
cleanse the skin,
I call it
pat dry.
vagina.
Please don't rub it. Just pat dry gently or air dry it. Approximate it, okay? When the skin flap is dry, if you don't approximate it, again, this skin will turn like a piece of raisin. It's gonna just shrivel up and die because it has no blood vessel. And then we will have to cut those, lift those wounds. Don't do it, let the doctor do it or let the RN do it, because you mess around and cut the patient's skin. But we have to get that off because that's just dead, hanging skin. If there's any bleeding, we'll deal with it appropriately. We want the flap to stay in place for the next few days, and then we're gonna document the size and whatever treatment we did, put it in a chart, and call it a day, and watch it like a hawk. Esa es nomás. Right. Biopsy, your diagnostic test. The big one is going to be a biopsy. What are we looking for? Cancer, malignancy, all right? Take a piece of skin,
Color.
blah, 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 blah. Okay, moving on. The next test that we're gonna do for diagnostics is the CNS, all skin stuff, CNS, we're gonna see who the pathogen is. Okay? And so it is what it is. All right, next on the list, weeping. Whenever we have issues with weeping, anything like that from a lesion, we want to use standard precautions. Any blood and body fluids is standard precautions. What is standard precautions?
I'm washing your gloves.
Wash hands and gloves.
It's not enough.
Medical sepsis.
Your answer is, it depends, Ms. Humes, on what the patient is presenting with. If your patient is presenting with this big old pus pocket, you might want goggles. You might even want a gown, and that is considered standard precaution. I'm not gonna walk into a room with a patient with a big pustule that's just waiting to explode with a pair of gloves on. So your answer is, depends, Ms. Humes. I am going to gear up appropriately for whatever it is that I'm dealing with. Vice versa, I'm not going to walk into a patient's room with goggles and gowns on for a skin tear. Right? So your answer, it depends, Ms. Humes. What does the wound look like? Is there a risk for splash? I need goggles, universal precautions. Is there a risk for rupture? I might need a mask. Is it a skin tear and there's no bleeding? I just need some gloves. Depends, Ms. Humes, on what I'm walking into. It's standard precautions. Okay. And so any, fluid, blood and body fluid, just don't touch it, don't touch it. Okay? All right, what else is on the list? We do some microscopic tests, and we will swab and scab and send things to take a look at. We're going to learn about the, I'll show you that later. We have Woods light. Every now and again you might be asked to get the Woods lamp. This is probably when you're in urgent care, those of you that go to urgent care, you'll be asked to get the Woods lamp, and that is an ultraviolet light. What we do is we put that light on the area of the skin, and we can see different types of pigmentation, what's going on with this patient. The other thing that we will do with the Woods lamp, or a slit lamp, you'll hear the term slit lamp, and this is a patient with a corneal abrasion, and the physician will ask you if you're in the urgent care, or sometimes even at the bedside, they'll say go get a fluorescein strip, and the fluorescein strip will turn the eye. The fluorescein strip, when it comes in contact with the eye, will turn this color, and then they'll ask you for the slit lamp, and they'll put this light, they'll shine this light there, and you'll see the fluorescein dye accumulate into the abrasion. So you'll see it'll fall right into the scratch. So this is how we check for corneal abrasion. So we use different types of light for that. All right, patch tests. I think y'all know what a patch test is by now. We try to do them in inconspicuous area. People with allergies, and we want to start checking them. Try the back, somewhere around here, where like don't do it on the cheek or nothing like that.
They do it on the back.
Small pieces.
We're checking for some type of allergen. What is this patient allergic to? All right, for your diagnostic test, the basic shindig, if it is invasive, you need to get a consent, you want to explain the procedure, and allergies, I agree. I was checking for allergies before we start giving this stuff, right? Label the biopsy appropriately, make sure they're following up to get the results of the biopsy, blah, 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 blah. Okay? Your two biggest concern of the integumentary system, pain
Infection.
and pruritus.
Oh.
Your two biggest complaints. Patient come and they're complaining, either the thing hurts or it's itching. That's what brings people in to get this integumentary system checked out. The thing is itching or it's hurting. So then we go and we start doing our history taking, and we try to figure out what's going on, why it happened, all that good stuff. All right. Keratosis or keloid, overgrown scar tissue, especially on darker skinned people, especially on black people. We keloid a lot, but not saying that other cultures don't. Latinas keloid too. I've seen little Latinas with keloids on them too, especially the ear, when that piercing goes wrong, and you got to take out that ear, and it's just that big thing. Michael had one, big old ball in there. Like, where did that thing taken off? So there's a keloid. And basically a keloid, most of the keloids, we're very, very careful about keloids, especially in black people, when the skin isn't approximated. Black people should not be stapled. Black people should not be stapled. Because with keloid, we need perfect approximation. Now, other races can be stapled, and life is grand. They don't keloid. So I have 2 C-sections, and so the first one, he stapled me, and life was grand until I started to keloid. And he was a he. I said he.
The doctor?
Yeah, he. So he stapled me, which is perfectly logical, right? How many of you have been stapled? Anybody stapled head? C-section? No keloid for you. I keloid. I can't be stapled. What happens with staples? You're not perfectly approximating that area. There's some little areas that are still going to be between the staples that aren't well 100% approximated. So then when I went back for seconds, because I can't just have one kid. No. Went back for seconds, and my OB was the chief of OB. She was on call that night. Lucky me. She said, "What the hell is this?" And I thought it was normal. I was like, oh yeah, girl, we're gonna cut this thing off of you, okay? I said, okay. So she did the C-section, cut all that skin off, and she stitched me to perfection.
Wow, nice.
Stitched me perfectly. That was in the hospital. I was like,
Well,
oh,
do we have elevation?
Hmm?
Are they all elevated?
What?
Keloid.
Keloids? Typically, yeah, because it's just a bunch of granular scar tissue on there. Most of them are just big balls of scar tissue.
I have a dog bite, but it's not elevated. It looked keloid, but I don't know.
Is it a scar or is it just a keloid?
Show us.
Oh, oh.
That's just watermelon.
Ah, just a scar, not quite a keloid, it's a scar. It's a scar. Keloid will be big like this. Whose dog was you messing with? Oh, there you go. All right, your physical assessment. Big scar, but not keloid. What are you doing for your physical assessment? OMG. This thing goes on and on and on. We don't have enough time to cover the physical assessment with them. You're looking at the patient's color. You're looking at the patient's skin. Is it intact? Is it not intact? Is it an excoriation? Is it an abrasion? Or is it a cut? Is it an ulcer? Or is it this or that? So there's a whole lot of shit going on there. But number one, please provide for privacy. And so you got to palpate areas of pain, warmth, tenderness, all that good stuff. What had happened? Skin turgor tells us what? About fluid volume or fluid hydration. So please don't do skin turgor here on old people. All of their hand is wrinkled. It's going to stay, what's the word that starts with a T?
Tented.
It's going to stay tinted. Okay, I got a couple more years left before I stay tinted. But they're going to stay tinted. So where do we do skin turgor? On, okay, so we can use the chest. All right, they're going to stay like that. All old people, they have it like that anyway, so don't go do that. All right, so we talk about tenting, and we see tented with fluid imbalance. Yes, which imbalance? Dehydration. So we want to use the upper chest for them. Alrighty, so tenting means dehydration. Moving on, edema. We gotta measure edema. Well, how much edema does a patient have? I don't know, +1, +2, +3, +4. It makes a huge difference. And so depending on how far down we can go, then you got issues with edema. What is edema? Fluid in the interstitial space. Which electrolyte or which, who's usually the culprit with edema? Yeah, but which
Sodium.
constituent of blood? What does albumin do? What does it do? Not what it is, what does it do? Albumin pulls fluids and keeps fluids in the intravascular, space. Your patients with hypoalbuminemia, the fluid comes out of the intravascular space where it belongs and pulls into the interstitial space. Albumin is usually your culprit. It is some protein. So albumin keeps fluid in the intravascular space. You'll see it again over and over and over again. All right, so issues with edema, and so it is what it is. Now, I'm gonna skip over these, for they are listed in your book very carefully, and I have given you the ones that you need. They're on like 3-4 pages of charts there. So macule is pretty much a flat area. We call it like freckles or moles, something like that. Papule, it is an elevated area, usually a solid lesion in there, such like a wart or an elevated mole. A vesicle is a papule that has fluid in it. For a papule is a solid lesion, but a vesicle is a serous fluid. So a vesicle is a papule with fluid in it.
Do you know what it is again?
Those vesicles, like chickenpox or herpes, or second-degree burns, we're going to see lots of vesicles in second-degree burns as we move on. Plaque, that shiny, scaly patch of skin is plaque, such as in psoriasis, not cirrhosis, psoriasis. A wheal, nice firm little wheel that you make. You guys did all these wheels when you made, when you did practice your PPE, practice your TB, skin test. We also see them with insect bites or urticaria. A pustule is a vesicle that is filled with pus. We call it back pimples, acne. All right, how do we apply these shindigs? Number one, for powders, I'm gonna skip over, okay, powders. Please be very careful with powders, they get in the airway.
That's not true, is it?
There's some medicated powders that we will use, but please be very careful with powders because they get in the airway.
I gave a powder at a sniff, and it was like the one where in her folds, she had like so much crusty and like reddishness in her folds that we powdered her folds of her skin. She was like very fat,
She more than likely had candidiasis.
probably, but we put powder in it.
Be very careful with those because, they,
That's it?
they
Thank you.
can get into the airway. Please make sure with all topical medications, the one thing you, ladies and gentlemen, please take off the old Shindig. I can't tell you how many times I've seen patients that come in with powder cake on top of powder. Or calamine cake on top of calamine, or Desitin cake on top of. Please take off the old layer and clean the patient's skin, and then apply the new layer, as needed, okay? With ointments and creams, please don't put your hand in the cream or the ointment. You must use either a tongue, depressor, or a gauze, or a cotton Q-tip swab, but please use an inanimate object that is clean, and then apply it. But please don't stick your finger in there, or you can use a gloved hand, but please don't just stick your fingers all in there. And then take the gloved hand and double dip, and then wipe it on the patient, and then get some more and put it on them again. You've just contaminated the entire vial stuff with whatever it is that's on the patient. So maybe get some cotton Q-tips, and then, a couple of them if you need to, okay? Only use small amounts, okay? Excessive ones over them is a waste of the product, because it's not all absorbed. And when you see the patients again, they still have it on their skin. All of that is a waste. What needed to be absorbed was already absorbed, and the rest is just waiting for microorganisms to land on it. So please be very careful with those things, okay? Gels and lotions. I don't think your book goes into all the medications, does it? Okay, moving on.
Corticosteroid.
Be very careful, again, apply sparingly in a thin film, and, we gotta be very careful. As I told you guys about, permethrin already, this was on your, to-do list. Who looked it up?
Permethrin.
Permethrin.
Nothing
Okay,
in
then
there.
look it up then. I believe I said that on Wednesday before we left. Didn't I say something about permethrin before we left? Elamite, yes I did. We talked about rid, quail, mix, and elamite. I told you that you have a new thing, okay. Okay, you'll see it. I told you to go in there and tell me where you put it, how long you keep it on, when you wash it off, where you put it. That's what I said, I remember that through the migraine. Thick layers are wasteful, and they will kind of soften the skin. Corticosteroids, Please don't, be very careful with your corticosteroids. Remember, they are medication as well, okay? All right, moving on. This, you need to know all about it. I told you to go in your drug book. What do you guys do when you leave? Like Thursday and Friday?
Sleep.
You didn't tell me that.
You
Tired.
sleep all day Thursday and
And
Friday?
I go to work,
I know you get off for work.
and then I come home and I eat, and then like, I maybe like spend time with like my.
So the only time you guys are in that book is when you're here?
Oh,
Well, where's the permethrin that I told you to look up?
I
Who
cleaned
did it and why? Okay.
nice.
You didn't tell
Nice.
us.
Where's yours, Jackie? What happened to yours? Hmm? Mona, where's yours? Mhm. Jasmine, where's yours?
No, I don't remember you saying that.
Same.
I don't remember you saying
Oh,
that. I would have written
fleas,
it
I can't
down.
remember.
I had it written down.
Mosquitoes, all that good stuff.
Well, you should ask your.
Maybe you were thinking
Elamite.
about it, you didn't say
Look
it.
it up. Where's your notes from Friday? Where's your notes from Wednesday? Okay, Jamila, where's your notes from Wednesday? Let me see all your notes from Wednesday. How'd you do that? Why'd you do that?
What's your note card?
Why'd you do that?
She made a note card.
Why?
She just told me to.
Okay. Corticosteroids, antifungals.
She was told.
Okay. Now, this shindig, where are your pressure points? I know I did. Where are your pressure points? That was 1, 2. Accutane, permethrin, elamite, quill, rid.
Oh, yeah, never mind. I got it. You did say it.
Prone position.
Going.
When the patient is prone,
Lies.
where are their pressure points? Why do I care about somebody's pressure points? Okay, that's where they're gonna develop deep tissue injuries. If your patient is prone, where are they gonna develop deep tissue injuries? These places there.
Knees.
Not their back. They're
Iliac
prone.
Sacrum.
What pressure points, it's right there. What pressure points is touching the bed if they're prone?
Why would they be prone?
Knees and
Why would it be
iliac.
prone?
Bone.
Because their
Yeah,
back is
position.
burnt up.
If they have surgery.
Because they've had surgery, because they need to get off of the stage 4 on their back that they have been in supine position with nobody turning them, and now it's down into the bone and they can't lay on it anymore. For a bunch of reasons. So your prone patients, the iliac spine is where they're gonna get a DQ, and knees are where they're gonna get DQs. Those are the pressure points in the prone position. Questions? Patient that is sidelined, where are their pressure points? They get DQs on their ears, they get DQs on their shoulders, they get DQs on what's called the greater trochanter. You need a trochanter roll for this. This is called the trochanter. What's a trochanter roll? Any old schools in here? No old schools? We're gonna take a towel.
Towel.
You got it. We're gonna take a towel, roll it up, and get them a little bit of elevation off of that area so they're not laying directly on this. For some of us, it's actually bone on bed. There's mine right there. For some of us, it's actually bone on bed. Some of us got a little fluff, most of us just got a bone on bed. Bone on bed. What do you think is gonna happen here?
Speak for yourself.
What I just said, for some of us, it's just bone on bed. What about your 90-year-old, 80-pound woman? It's bone on bed. She's going to break down. She has nothing there. She needs a trochanter roll. This is a towel that we just roll up and just slightly elevate her off of that area so she doesn't get a trochanter DTI. The next place they're gonna get is the head of the fibula, and then of course, the lateral malleolus, you call it the ankle bone. Your supine patient is a no-brainer. They actually, we missed the back of the head. They do get the cubes in the back of the head.
Tends to be what the men without hair who get it.
Bone on bed. It's literally bone on bed. Anywhere where there's bone on bed, it's gonna break down. No ifs, ands, or buts about it, unless you do what? Turn them Q2. No air mattress.
I've
no-
never actually seen a patient at a facility turn Q2. I don't know if anybody has, who's ever seen their patient genuinely.
That's
turn.
why all those lawsuits that I had on the board the other day are up.
And the pillows, I mean, I know you can barely see it, but the pillows can, it helps. Getting
Does
those pillows
help.
under, just get a little bit even helps.
What makes it worse is sheets that are not taut.
The wrinkles.
A lot of stuff going on. So the scapulae, the vertebrae, the back of the head, the occiput of the head gets deep tissue injuries. Of course, the lower vertebrae, the sacrum is your big spot. Everybody, you know, is always on the sacrum. And then their heels. So what do we do with the heels? What are we supposed to do with patients' heels?
Put them, elevate them on a pillow
We
under
call it, you got it, we call it floating the heels. We float them off the bed. Elevating on a pillow, it does not even come in contact with the bed. It's always just floating. So you put the pillow here and the heel is up. Now, don't put the heel on a pillow. The heel is in contact with the pillow. But put it up a little higher and we float their heels off the bed. We put foot cradles for them, heel cradles for them as well, and so forth. So it depends on what's on with the patient. All right, let's finish DQ so we can, 5 minutes. What are the major risk factors? Everybody knows it. Incontinence, not turning, low protein, got the basic stuff. Is a big one, impaired mobility and blah, blah, blah. All right, what contribute to these things? All the good stuff that we haven't seen obesity in a while.